Thanks for taking the time to give this a listen. Given everything that's going on, I thought it might be a good idea to review where we are and try and put our current situation into a little bit of historical context. If you've been to the office recently or even into a bar or a restaurant, if anything like that is still open where you are, you probably noticed that things are slightly different now than they were a few weeks ago. The important thing to understand, though, is that the situation we're in right now is not unique. Plagues, virulent diseases are a feature of human history. They're something that's been around ever since humans gathered together into large groups for the first time 10 or 12,000 years ago. I've listed on this slide a few of the more famous incidents of plague diseases that have really impacted the course, certainly of Western history for the most part in these examples. The most famous of these is probably the Athenian plague of 430 BC to 425 BC. We don't know, of course, exactly what disease this was because medical science was not developed at that time. Based on descriptions of contemporary historians, we think maybe this was smallpox, although there is some evidence that this might actually have been the first outbreak of Ebola among the human population. At that time, about 50% of the population became infected, and about 25% of the total population of Athens at the time wound up dying over the course of this plague. And this actually occurred during the course of the Peloponnesian Wars between Athens and Sparta. Athens at that time was the first and only democracy on the planet. Sparta was a military dictatorship. And this plague ended that war, ended Athenian democracy, and handed the Peloponnesian War to Sparta for the most part. And that completely changed the course of the history of that part of the world. The Justinian plague took place in Constantinople in 541 AD. We know that this one, based on, again, contemporary descriptions, was the bubonic plague. In that case, about 60% of the population was infected, and Constantinople at the time was the largest city in the world. It was the capital of the Holy Roman Empire at that time. About 30% of the population of Constantinople did die during the course of that year, and this was a large contributor to the eventual fall of the Holy Roman Empire. Everybody, of course, is familiar with the Black Death, which struck Europe between 1347 AD and 1351 AD. This, again, we know was bubonic plague. There were a total of about 50 million fatalities that occurred during the course of those 4 years, or about 50% of the total population of the European continent. This obviously had an enormous impact on societies, on the course of European history, depopulated entire regions of the continent. And then if we look at the Americas, moving forward to 1545 to 1548 AD, and this is just one example of many that could be taken from this period. The Coctylizidi epidemic, we believe, was Salmonella enterica, and that killed 80% of the total population of central Mexico and essentially ended the Aztec civilization. There were similar plagues that occurred throughout North and South America during this period as Europeans came into the Americas and spread diseases from Europe and from Eurasia into the completely naive North American and South American populations. In fact, there's a famous story of explorers moving into the Mississippi River Valley and finding what they thought were the ruins of an ancient civilization, a grand ancient civilization. They thought had been abandoned for centuries. In fact, it had been abandoned for about 10 years because smallpox had moved in advance of the explorers and had wiped out more than 90% of the population of that part of the continent. If you want a little more background on this entire process, I highly recommend a book called Guns, Germs, and Steel by Jared Diamond. An important point to understand, however, is that what we're experiencing right now is not one of these civilization changing, civilization ending plagues. When we try to characterize how dangerous a disease is, how dangerous a plague is, there are two factors that we take into account. The first is the case fatality rates. If you contract this disease, how likely are you to die? The second is the contagiousness of the disease. And we characterize this by a parameter called R0, which is, in a naive population, how many people will one infected person spread the disease to over the course of their illness? If we look at COVID-19, we don't really know exactly what the case fatality rate is. Estimates range from about 0.5% to about 1.5 or 2%. It's difficult to nail this down until we have serum testing to determine exactly how many people may have contracted the disease and not wound up in hospitals, not in fact maybe even shown symptoms. But we know that obviously it has a very significant number of fatalities because of the number of people who have died already from this disease. We have a pretty good idea of the R naught value, and it's a little over 2 and less than 3. And so if we look at this plot, we've looked at a number of different diseases that we're all familiar with, that we've heard of before, and plotted them out. And the further to the upper right of this graph you are, the more dangerous, the more deadly this disease is going to be. And you'll notice that if we assume, say, a 1% case fatality rate, and we know the R naught is about 2.2 or 2.3, this puts us down on the lower left side of the graph. There are many diseases that are much more dangerous further up and further to the right. Things like bubonic plague, things like tuberculosis, which at one point killed something like 30% of the population of New York City. Polio, which we're all familiar with. Obviously, since the development of the polio vaccine, not so much of an issue, but in the living memory of people alive today, obviously an extremely dangerous disease. With more than 20% case fatality rate and R naught of 6, much more severe than this. Even things like smallpox, diphtheria, SARS, which of course emerged only in 2003, you see has a case fatality rate of 10% and an R naught value very similar to what COVID-19 has. So this is a dangerous disease, but this is not the sort of disease that is going to take down our civilization. So if you're sort of worried about that, we don't need to be in that space. However, it is also important to understand that that does not mean that this is not an extremely serious illness. This is a photograph that was taken by an emergency room nurse in New York City on a break. These are bodies lined up in a refrigerated truck outside the hospital. Obviously, we have already in the United States suffered more than 30,000 deaths related to this illness. There are a great many more people around the world who have died and will die over the next several months from this illness. So this is, although not something that is going to sort of Captain Tripp style destroy human civilization, it is something that is an extremely serious illness and something that we have to deal with in a very serious way. Something to understand about any plague disease is that any plague is best thought of as a failed negotiation. It is not in a virus's interest to kill its host from a biological standpoint. Not that viruses think or have any interests of their own, but from a strictly biological standpoint, what a virus benefits from most is a disease which makes its host slightly sick, enough to cough, enough to sneeze, to spread droplets around so that the virus can propagate, but the host goes on living, because when the host dies, all the viruses that are successfully replicated inside that host die as well. And of course, once a host dies, it can no longer spread the virus. So if you look at diseases which are well adapted to a population, diseases which have co-evolved with a species, they're almost never fatal. They're the sort of things like rhinoviruses, like the common cold, which circulate through the population, are annoyances. They make people a little unpleasant. They make people uncomfortable, but they almost never kill anyone. So when we see a plague disease, what we see is a virus which is ill-suited to its host. And that's explained by the fact that the vast majority of plague diseases are in fact zoonotic. They come from animal species and jump into the human population, or within animal species, jump from one animal species to another. So obviously we're not the only species that has to deal with these sorts of things. A much smaller number of viruses result from spontaneous mutation, from an old virus that maybe was not so harmful that becomes more virulent through mutation. That is a very unusual event. There are a few documented instances, but it's extremely rare. And then we have a very, very small number that are consistently endemic, and even the majority, and so things like smallpox would fall into that category up until the point that the smallpox vaccine was developed and smallpox was more or less stomped out. But even smallpox originated as a zoonotic disease, most people believe. So what do we do to deal with these plagues? Well, there are a number of approaches that people have taken. The Athenian approach, crowd everyone into the city. That's the first thing that Pericles, who was the leader of Athens at that time, did. Uh, Again, the Spartans were sort of rampaging through the countryside, and his population was becoming ill. So he drew everyone inside the city walls. He thought that would be the safest thing to do. Turns out that was not such a great thing to do because, of course, that encouraged the spread of the plague through the population. Uh, the infected people, because the suffering from this particular disease is described as an unbearable burning sensation, had a tendency to throw themselves into wells. Again, not ideal from a disease containment standpoint. Not only do you have now a dead guy, but you've got dead guys in your wells. And that means that your water is going to be contaminated, and that doesn't work out well for the people who are still alive and presumably uninfected. However, the one advantage to this approach is that eventually, over time, everyone in your population is going to be either immune to the disease or dead. And that is eventually how it worked out for the Athenians. But of course, at that point, it was too late. They had already been conquered by the Spartans. A much better approach to this sort of disease is the one that was taken by pretty much everyone in the world to the SARS epidemic in 2003. And that is to follow a fairly simple protocol of identifying infected individuals, isolating infected individuals, and then tracking any contacts that those individuals may have had in the past so that you can determine who else might have been exposed and isolate them as well. So I mentioned we have a parameter related to any disease called the R0 value, which we see plotted here. As you can see, SARS has an R0, which is very, very similar to what we have for COVID-19, about 2.3. However, SARS did not spread anywhere near as widely as COVID-19 did, because we took a very aggressive approach almost from the moment that it emerged, to identify people who were infected and make sure that they were not able to spread the disease. And in so doing, you're actually able to reduce the effective R0 value to less than 1. So anytime you have an R0 value of 1 or greater, that disease will propagate and spread, and the number of people infected will continuously increase in the population. If you can get the R0 value through medical intervention, through vaccinations, through isolation, through other approaches, below 1, that means each individual who's infected is infecting less than 1 additional person, which means that over time, as the infected people either die or get well, the disease will die out in the population. And that's something that we did successfully with SARS, and we clearly have not done successfully with COVID-19. So that raises an interesting question. Why haven't we done that successfully with COVID-19? And the reason why is not just because of fecklessness on the part of different governments or anything else. It's because there's a critical difference between the way that COVID-19 spreads and the way that SARS and many other upper respiratory tract diseases, such as influenza, spread. And that is that with COVID-19, every evidence indicates that a significant fraction of people who are infected with this disease do not show symptoms. There is a substantial incubation period between the time that even people who will become symptomatic are infected and the time that they begin to show symptoms. And here's the critical piece. You are able to shed virus and infect other people without being symptomatic. And that was not true of SARS. With SARS, people were not contagious until they were symptomatic. So it was fairly easy to identify people, because the disease was so severe, who were sick, and isolate them before they can infect many other people. That's proving much, much more difficult with COVID, because by the time you begin to show symptoms, you may have already infected several other people, because you're already shedding virus for that 4 or 5 day period before you begin to show symptoms. So if we can't exactly identify everyone who has this disease and isolate them specifically, we have to take a second approach, which is, from an economic standpoint, much more painful, which is to isolate everyone. And that's essentially what we are attempting to do with the closures of economies, lockdown procedures, and so forth, is to, because we can't identify exactly who is infected, essentially assume that everyone is infected and put everyone in quarantine. And this is not something that can be done forever, obviously, and that's not the point. The point is that we know that the case fatality rate for this disease is much more severe if people who become heavily infected and are having problems with the disease are not able to get the health care that they require. In particular, things like oxygen support and potentially ventilator support to get through the critical phase of the disease. That may mean the difference between a 0.5% case fatality rate and a 5% or greater case fatality rate at the end of the day. That means that we have to limit the rate of infections such that we never have more people flooding into our healthcare system than the healthcare system is able to handle. Some societies are doing that fairly well. A lot of the Asian countries have been pretty effective in isolating, tracking, and making sure that the rate of infection is kept below what their healthcare systems can handle. Obviously, places like Italy, Spain, areas of the United States have not been as successful with that and have seen in surge times their healthcare system basically being overwhelmed. And that's something that we really want to avoid because you wind up having people who would have otherwise survived the disease not surviving because they're not able to get the medical support and the medical care that they need. So that's why we're going through these isolation procedures, is to try to keep that curve low enough that the peak of it never exceeds the base capacity of our healthcare system to deal with these patients. So where do we go from here? Well, there are three basic approaches which different countries have taken. Number one is the gutted out approach. Forget about social isolation. Just let people go about living their lives. Understand that lots of people are going to get infected. We know that most people who will get infected will recover. Some will be severely compromised. Going through a bout of this disease can lead you to scarring in your lungs that can last for the rest of your life, can compromise your ability to do things moving forward, can compromise, potentially shorten your lifespan from other diseases that you might pick up in the future. But a lot of people won't have symptoms at all. Maybe as many as 50 or 60% of people who contract this disease will never show symptoms. And essentially the assumption there is that our society can absorb a certain number of deaths. That is an approach that is being taken to a certain extent in Sweden right now. There are people who are advocating for that sort of an approach in the United States. To me, this seems like a really, really poor approach, both from a basic humanitarian standpoint and from an economic standpoint. If you look at the long-term economic outcomes, for instance, from the 1918 flu epidemic, which is probably the closest analog to what we're undergoing right now, the cities that locked down very heavily early on in that flu epidemic and curtailed their own economic activity, but preserved the health of their citizens, wound up growing much faster from an economic standpoint in the subsequent years after the plague had subsided. Whereas cities that were much less vigilant about locking down their populations during the peak period of the plague had much slower economic growth moving forward over the period of the 1920s. And so there's plenty of evidence out there that taking some economic pain right now actually is the most beneficial thing to do, even from an economic standpoint, completely setting aside the humanitarian concerns, which, at least to my way of thinking, should win out in this case in any case. The approach that we're taking right now is number two, which is to stretch things out. We know that we cannot entirely stamp out this disease. Again, you can't keep everyone in isolation forever. That is understood. But what you can do is limit the rate of infections. Try to protect the most vulnerable people and try to keep the number of people who are sick and requiring medical support at any given time to a minimal level, to a point where the healthcare system is able to give everyone who needs heavy support, everyone who needs oxygen support, everyone who needs a ventilator can get those medical interventions, and therefore the maximum number of people who can come out the other side do come out the other side, and we limit the total number of deaths to the absolute minimum. Obviously, there is economic pain that's associated with this approach. There's also humanitarian pain that's associated with this approach. But at this point, it's probably the best approach that we have available while we wait for number three, which is science to the rescue. And what we mean here is some combination of a vaccine, which, of course, many, many people are working on right now. The process of generating a vaccine is a lengthy one, and the process of testing to make sure that any vaccine that is generated actually works is also a lengthy one. That process is already underway. There are a number of vaccines that are already in the clinical trial process, already in the pipeline, but we shouldn't expect vaccines to be widely available for probably at least another 12 months and possibly longer than that. But in the meantime, we can also look at treatments which may be effective to limit the severity of the disease for people who do get infected. And there are a few approaches that are being tried there. You may have heard of hydroxychloroquine, for instance, something that's being pushed by a lot of people as a potential treatment. The important thing to understand about hydroxychloroquine is that this is an anti-malarial drug. It is not an antiviral. It does not have a direct effect on the disease. So people were talking about hydroxychloroquine as prophylactic for this disease are exactly wrong. They are taking the opposite to the optimal approach, because the effect that it has on these patients, on COVID-19 patients, which may have benefit, is in the fact that hydroxychloroquine is in fact an immunosuppressant. It suppresses the activity of your immune system. Now that sounds paradoxical. Why would you want to suppress the activity of your immune system when you're sick or you're worried about getting sick? Well, the answer is, when you're worried about getting sick, you wouldn't, you shouldn't. So taking this drug when you are not infected actually may potentially increase the possibility of being infected, because you are suppressing your immune system. Where this drug has benefit is in the fact that many people who die of COVID-19, just as the majority of people who died in the 1918 flu pandemic, did not die from the activity of the virus per se. They died from what's referred to as a cytokine storm, which is when your immune system goes into almost a suicidal overdrive. It begins to crank up to the point that your immune system actually destroys your tissues and kills you. And because hydroxychloroquine is an immunosuppressant, and that's where it's used most often right now, is with patients with autoimmune disorders and things like that, where they need to tamp down their immune system. The thought is that it can potentially mitigate the effects of these cytokine storms and allow people to get through crisis points when they're already very, very sick. So this is not a drug that should ever be taken by anyone who's well. And it is, I should also point out, not a drug that should ever be taken except under the strict supervision of medical professional, because in addition to being an immunosuppressant, chloroquine and all of its derivatives have the effect of what's called QT, interval prolongation, which means they make changes to your heart rhythm potentially, and those changes can be dangerous to deadly. QT, interval prolongation, can lead to ventricular fibrillation, which can lead to sudden cardiac arrest and death. So this is a very, very serious drug. It is something that if you are in the midst of a cytokine storm, may be worth the risk of taking. And that's how medical professionals are using it right now. It is not something that should just be taken, as a prophylactic or because you're afraid you might get sick. That is a very, very, very dangerous thing to attempt to do, and should not be pushed by politicians right now. That's a huge, huge mistake that people are making. There are a number of other drugs that are in the pipeline, however, which may have more direct effects on the virus. You probably read about Gilead, pharmaceutical company has come out with an antiviral drug, which was originally developed during the Ebola crisis in 2014, but there is some preliminary clinical evidence that it may have beneficial effects on COVID-19 patients. So that's, again, something that is in the works. We should have results from clinical trials coming out over the next few months for this drug. There have already been some results that have been posted that appear to indicate that there may be some positive effect for this drug. But again, this is something that is going to require more time and effort. We may start to see some of these drugs moving to approval by regulatory agencies and starting to move into the general population by the late summer. That is the best hope at this time. And then the final approach that people are taking is to do artificially developed antibodies. And so probably are all aware that the effect of a vaccine is to cause your body to produce antibodies to the infectious agent that you're worried about. So that's what happens when you get a vaccination. You are priming your immune system for the particular virus that you are being vaccinated against. your body produces antibodies and memory T cells that remember what that virus looks like. And so if you ever encounter that virus in the wild, your immune system is able to crank out antibodies very, very rapidly and suppress the disease. And that's how you wind up clearing the illness. The approach here is to develop artificial antibodies, which are specifically designed to destroy COVID-19, and then inject them into a patient who is infected with COVID-19 or who may be infected. This is actually something that could provide temporary immunity to COVID-19 if it works as the scientists who are developing this approach hope that it will work. Now, it would not have the same effect as a vaccine because these are artificial antibodies. Your body doesn't produce them naturally as it does after you've been vaccinated, but you could flood your system essentially with these artificial antibodies, and although they will deteriorate over time, you could have 6, 8, 10 weeks of artificial immunity to the disease, and then you would need to get another injection. So this is not something that would be good for the general population because these injections, developing artificial antibodies is extremely expensive, and these injections would be extraordinarily expensive. But it is something that might be useful for protecting our healthcare workers. If you're a frontline ER doctor or a pulmonary therapist who has to work with these patients closely, it might be worth the investment if these investigational agents pan out to begin to provide these sorts of safeguards to people who are frontline workers to keep them healthy while they are trying to keep the rest of us healthy and alive. So that's where we are right now. Hopefully we continue to progress and things get better over time. That's what we hope for. Things obviously may go up and down as we progress, but the important thing to remember is that this sort of thing has happened before, many times in the past, many times much worse than what we're going through right now, and this too shall pass. So there is a light at the end of the tunnel, and we will come out the other side. It's just a matter of making sure that as many of us as possible do come out the other side. Thank you.